thank you everybody for coming to this presentation. It's one of those presentations that for some families it's going to be a little bit difficult. So I do want to advise anybody who's online or even here present that there may be times that you feel triggered. So if you're feeling after this presentation that you need to talk to someone, I would certainly access your support system that's out there. It is a difficult discussion. It's one that does not happen frequently enough. So I'm honored to be able to give some insight and education about what is happening in particular to parents. The whole subject of children is another place because they too do have post-traumatic stress and can be diagnosed with post-traumatic stress disorder. So that's a whole other presentation. So I'm focusing only on parents for today. There will be an opportunity after the presentation to ask questions. So once I'm finished, I'll open it up to questions. And I know those that are online, you can type your questions in and I will be happy to answer them. So what I want to educate and help people become aware of is really three processes today. One, I want to talk about normalization, because a lot of times we hear this informally amongst parents. We're all trying to talk about our stories and our journeys, and we're trying to normalize it for each other, but we're only talking about our stories. And so how it is important as formal supports and informal supports, so whether you're a professional in the hospital or out in the community or even your informal supports, how important it is to validate that what you're experiencing is normal. So I'm going to talk a little bit about that, and then I'm going to move into the difference between post-traumatic stress and when we become concerned about post-traumatic stress disorder. So I am actually going to identify what PTSD is based on the DSM. So I'm going to talk a little bit about that. So the first thing I want to do is I really want everybody to understand what is happening in the brain. Because a lot of times when people think about mental health, we begin to blame ourselves, and this isn't about blaming ourselves. So I really want everybody, I'm going to do a little activity here. This is a great way to think about your brain. So everybody has to participate in the room. So what I want you to do is I want you to grab a hand and put your hand up. Okay? So then I want you to, I know that everybody online won't be necessarily able to see this, but I'm going to hopefully describe it well enough that you can at least try to do it. So then what I want you to do is take your thumb. So if you, right now what you see is, if you were to think about this as a model of the brain, so this is just a model, this is not exact, so it's a model. So what you're going to see is that this part is your central nervous system. So then the next thing I want you to do is recognize that this part in here is your brain stem. So this is where your breathing, all of the big functioning happens. This part I want you to fold over. This is your limbic system. This is where your amygdala and all of the emotional part of yourself. So this part is connected to this part of your brain. So then you take your top of your part of your fingers and you're going to fold it down. So this is your cortex. That's all that wrinkly stuff that you see in the imaging. So this is the thinking part of your brain. So when you are under stress, so we open our hands back up, we put this part, the fight versus flight and also freeze part of our brain is happening here. When you become traumatized or stressed, this is dysregulated, okay? So what we need to do is we want all parts of our brain working together. There's many reasons how we get that to work together. But right now, what I want you to do as we're doing this presentation, that when we're talking about trauma, your brain is dysregulated, okay? You're in fight-flight response. So how do we help ourselves when this is happening? Okay, so I want everybody to remember that part. So you're moving it from feeling responsible to understanding how our brain mechanisms actually cause us to feel overwhelmed. The other part you have to remember is if we look at the central nervous system, we have neurological matter that's around our intestines and around our heart. All of this is working together. So if we're in a traumatic state and we're thinking about parents, we're seeing lots of trauma in their medical journey, we want to be considerate that rather than blaming ourselves, think about what's happening to our brain in that moment. Okay? So I'm detaching it from feeling responsible. We know that as you're beginning your journey, this is an abrupt change. And so there is this sense, and I hear this comment, that we were this normal family with normal worries, and then it all changed.
Sorry, if there's somebody on the phone, we can hear you. If you can please mute your phone, and there'll be a chance for Q&A at the end.
So then in a matter of moments, matter of overnight, things changed. And that in itself, when we think about how instant your life completely changes and how traumatic that is for parents, for the siblings, and for those around you. So it's something to be aware that in that moment, trauma begins. So normalization. So again, we want to start there. What is a normal and common reaction to a parent who now is faced with the childhood cancer journey? So the first thing we want to normalize is understand that these are normal thoughts amongst all parents. A fear of your child dying, and for some families, this of course is the reality. And at the beginning of the journey, it is often very present. It's one of the first and foremost thought that surfaces. And that is such a traumatic thought to have. And of course, it's going to be overwhelming. Intrusive. These intrusive thoughts occur at any given point, at any given time, and often it comes as a shock for most parents, is where did this thought just all of a sudden surface? I don't know what brought it up. It's very normal to have thoughts that just surface at any point. Memories that can't stop or you can control. Very common. You could be in the car driving and you will keep rehearsing these memories over and over. Very normal. I'm going to move into when it becomes concerning, but right now remember, when I'm talking about this normalization phase is something that everybody experiences and occurs in the first 30 days after diagnosis, okay? Then, very common, and this is something, I mean, even when I can imagine being in the hospitals, so many parents that blame themselves. They were looking for blame. Did I do something? Did I not do enough? Feeling like you're the bad parent that you caused cancer. It's such a normal thought that surfaces. Then the feeling and sense and thoughts around hopelessness for the future, that a cancer just creates a sense of despair, that you feel overwhelmed, and seeing into the future just continues to seem despairing. Another normalization process is feelings, feeling worried about your child, and often feeling worried about your other children. So it just doesn't occur just with that one child. You become a lot more overwhelmed about your other children, wanting to protect them. Feeling jumpy or on edge, because remember, our fight versus flight response is activated, so we're going to feel jumpy. It's a very normal response when there's danger or trauma occurring. Feeling helpless or scared is so common, and not just in the hospital. You can be feeling this way at home. Feeling emotionally numb, overwhelmed with guilt and shame. So again, if you think about guilt and shame, why would one feel that way? Because if you are blaming yourself, guilt is going to be very, very prominent for a parent. Actions. So again, being protective. These are behavioral actions that a parent will take as a result of a diagnosis. So they become protective of your children and often your other children. Avoidance behavior. So you're avoiding anything that has to do with reminders of the hospital, treatment, anything. So this could mean if you've had a story with a family member or friend and they perhaps didn't validate you in a way, you may avoid that person. You may avoid, we had an experience at a grocery store. It didn't go well. I'm going to avoid the grocery store now. You end up avoiding places that trigger any traumatic experience. And sometimes it's not a traumatic experience in our brain or a thought. It's just we feel sick. We go to the grocery store. We don't like it. We feel sick. I'm going to avoid this spot. So you have to be very aware of what physically you're feeling because that too is a trigger. Not eating or sleeping or taking care of yourself, very common. I mean, sometimes the medical journey results in us not being able to do that. So as a parent, very, very common. Maintaining relationships, also very common. And not just because others don't maintain it, it's that we, as parents going through this journey, you struggle maintaining that as well. Again, that's all based on avoidance, avoiding those social relationships. Physical symptoms, so again, we're thinking back to the brain, what are our physical symptoms? Fight versus flight response is activated. We're going to be in a hyperarousal state, so we're going to be feeling dizzy. We might have heart palpitations. We may feel these very strong physical sensations. When you're reminded of an event, and again, this can occur anywhere, okay? So these, again, are very normal. The thing about the medical journey for cancer with children is that research, when we look at the research, they cannot identify any one particular event that causes trauma. Because when you think of the childhood cancer journey, there isn't just one. There is diagnosis, there's treatment, there's so many possible traumatic events. So we know that it isn't just one traumatic event. And the more you experience, the more difficult time that a parent will have. So when we're looking at the traumatic stress reaction, so what I identified, yes, these are defined as post-traumatic stress reactions, not PTSD, because we're not at that stage. These are within the first 30 days of a trauma, okay? So this is, even though it's normal, and these are normal experiences, this is one of the first things that will occur. So we're going to summarize this, and the first one is re-experiencing. So the idea of re-experience is we have memories, we replay it over and over and over. And it's like we're rehearsing this story over and over. And our brain actually does that for us because it's your way of your brain integrating it so it can adapt. So we want to re-experience it. It's a healthy response for your brain. It becomes unhealthy when it continues. So the first 30 days, re-experiencing, everybody's probably thinking, yeah, I can remember doing that, or perhaps still doing that, and I'll again talk about that. So re-experiencing a very healthy response, recognizing it's okay. We want to help figure things out. The second one, avoidance. So again, what does avoidance look like? We're avoiding everything to do that reminds us of the traumatic experience. So again, if you continue to add more trauma experiences with the childhood cancer journey, again, the more you'll want to avoid. So avoidance is people, places, situations, even thoughts and even emotions. Some people, detaching from those thoughts and emotions can be very overwhelming, so let's just remove them. Let's avoid anything to do with that. So again, it's not just external environment, it's also internal, how we're doing. So sometimes avoiding those thoughts and experiences. The third one is hypoarousal. So I talked a little bit about that, and that hypoarousal is the concerning where it can lead to further struggle. So again, fight versus flight, and often freeze mode is activated. So the idea with fight and flight, we have the option of doing one or the other. So if you think about a parent with a childhood cancer journey, what is the most common feeling? We're feeling helpless. We have no control. We're powerless. So we're actually in this freeze mode. There's not a lot we can do, unless, sure, there's sometimes we can fight, we can advocate, but a lot of times we're feeling a little bit stuck. So in that state, we become very overwhelmed. We are not sleeping well. You're not eating well. In that hyperarousal, you're sweating. You're physically overwhelmed, which then causes continued impact on your life. So hyperarousal is a very common. In the first 30 days, this is where you're trying to do as much as you can. The problem becomes when these things become persistent and excessive. The first 30 days, most of the time people can move beyond, yes, it comes up, but we want our system to calm down. It's when our system cannot calm down anymore. I wanted to show everybody a graph. And so this graph was just research findings. It really shows where pediatric cancer falls in terms of the traumatic stress symptoms for a medical event for parents and their children. So when we looked at we'll strictly look at the parent one, you can see that for parents, 35% of parents do have post-traumatic stress symptoms. So those are the findings at the Children's Hospital of Philadelphia. Most will have early onset experiences, and then, of course, as it begins, most will be able to adapt and integrate all of that. Then you've got the additional, if you have a transplant, a child who's had a transplant, that, of course, becomes a lot more significant. If you think about putting those two together, so again, more trauma, more post-traumatic stress symptoms. So this was just a good example of identifying the research that is beginning to develop. We're still in developing phases of research for pediatric stress and PTSD. For parents, it's been happening at this particular Children's Hospital, as you can see, since actually they've had some research since the early 90s. So there is research that's coming out. So when should you be concerned about PTSD? And there's two pieces that make this really significant. I'm going to show you the DSM criteria that actually identifies PTSD. The two concerns with PTSD is when you look at the post-traumatic stress, it is when those symptoms become persistent and you no longer can function. That is when we get concerned. So those symptoms that I shared with everybody, post-traumatic stress, are similar, as you will see as I draw upon the DSM, are very similar to PTS. But again, the two significant pieces in this, is it persistent and are you no longer functioning? So We're going to look at the criteria. So, and it's all based on meeting each of these criteria. So the first one that you need and required for PTSD is direct exposure. And what's interesting about this, and I'm just going to have everybody highlight, when you think about your own journey, we're needing one requirement for a stressor. When you think of a childhood cancer journey, a parent is not just directly exposed, they're indirectly exposed. So the other thing is that vicarious trauma is very real. There's lots of research out there talking about vicarious trauma. So all the parents who have their own story are listening to other parents' stories. And how overwhelming is it to hear other parents' stories in addition to walking your own journey? So that vicarious trauma is very significant. So here we've got direct exposure, we have indirect exposure. A parent who continues, so the other one is repeated and extreme. Childhood cancer journey is repeated. It is extreme. So this isn't for parents who are walking this childhood cancer journey. It's just not one criteria. I think we could all agree that a parent meets probably all of those stressors. So that's what's significant. That's why when I started talking is that they can't identify one particular trauma that might be the epicenter of trauma for PTSD, because there's multiple. And this is why it's so important that research continues for parents and their children. So the second criteria is intrusive symptoms. So very common, again, as we saw with post-traumatic stress, the early beginning is there is intrusive thoughts. It is recurrent. It is involuntary. It happens out of nowhere. You just could be sitting in your car and this occurs. Nightmares. So the thing with traumatic nightmares, you're not necessarily having nightmares about treatment. You could be just having nightmares and wake up and think, oh my goodness, what was that about? So nightmares is the common theme. It doesn't necessarily mean it's about your child's medical treatment. It could be you're just having nightmares every single night. And that is overwhelming. Flashbacks. Flashbacks to a particular part of the treatment can occur. And depending on how, and this is where it gets serious because we do call that some individuals who have post-traumatic stress disorder can become disassociative. That it's your brain's way of shutting it down, want to avoid that trauma, so they go into this state to protect themselves. It's a very healthy response for the brain, but not helpful for the person who needs to function. So that can happen, and it can happen in the form of a flashback. So it's very, very overwhelming for people. So distress, intense and prolonged. And again, remember, we only need one of these requirements for a PTSD diagnosis. And then we go on to the next criteria, which is the avoidance. So we talked about this again. You'll identify this as similar, but remember, it's persistent. You're not wanting to experience anything that you experienced prior to the diagnosis. Anything that you want to avoid becomes persistent. You are perhaps withdrawing from life. You're at home. You're not getting involved in your social outings. You let go of lots of things. And this is where it gets serious, is avoidance. As a parent, you have to continue taking care of perhaps other children. You have to continue to go to work. There's things that you can't avoid, whereas the concern at this stage, when someone has PTSD and a parent is struggling, is they're beginning to avoid life. And that's where it is important to recognize when you need to get help. And one is only required for that criteria. So then the next one is which is 2, so it's the change in mood and thoughts. So you'll see, again, the word that you want to see is persistent. That is the significance of the DSM diagnosis for PTSD, is that when things become persistent. So persistent in negative beliefs, persistency around blaming yourself or blaming others for the trauma, persistency in not being able to see anything positive in your life or having positive emotions. All of the emotions you experience are fear. It's all based on the hyperarousal state that you're in. So you continue to detach. So this is very common. Again, you can see from the DSM, it's 2 criteria are needed for this. So the last 3, I'm just going to pull up the last 3 right now just so we can see. The next criteria is just changes in your behavior. So it's your responses. So we can see that when you're at this state, yes, can you become irritable, and some people become aggressive as a result. Is there self-destructive behavior? There's parents that when you remove the good things in your life, you become self-destructive. This is what we call maladaptive coping. This is utilizing drugs, alcohol, anything that is not actually what we call sustainable health. We want really good coping. And I'm going to get into talking about what we should be doing for ourselves. But this at least highlights for everybody normal responses post-diagnosis, going into what is actually we call post-traumatic stress and when we get concerned. So that's important to remember. A startle response. So this is, again, hyperarousal state. Anytime you're sitting in a chair, you could be extremely startled, and it could be anything. Someone walks into the room and you find you're jumpy. That no matter where you are, any slight shift, any slight noise, your startle response is there. So remember, your brain is activated. It's constantly in danger mode. So you're going to be very aware of what's going on because your body wants to protect itself, right? It's getting ready. I'm in danger. The reality is you have to have your brain shut down again because it's there to respond. Your digestive system shuts down. Everything else gets ready to help get you ready to fight or flight. But when you're completely activated all the time, you can't cope, you can't manage, and when the danger is not present, every day there isn't danger that's present, we become overwhelmed, and it can lead to many things. So sleep disturbance, of course, very common, but when does it become alarming? Sleep is so imperative to self-care, and so it's often the first one I hear, I'm not sleeping well. Very common, but it's so significant for your own mental health. The duration, so again, I talked about these two. So the criteria for this is that more than 1 month. And the thing about PTSD is lots of people will say, well, I've been fine. I'm okay for a year later after diagnosis. Sometimes you can find that up to 2, 3, even longer PTSD can occur. So just because you're fine the first year, it's always good to be very aware of yourself and how you're doing, even when treatment may even be done. Because a lot of times, these type of symptoms can occur when treatment is done because it's all of a sudden when you've allowed yourself to start processing the events that you've gone through. And this is where sometimes parents can start having these type of symptoms. So the most important thing is to always be aware of how you're doing, how you're functioning, and how you're feeling. And again, the other part is when you're no longer able to function. So that's the last criteria. If you're not functioning well and there's an impairment, you're not able to attend work and you're not able to socialize. So good 2 baselines to check in with yourself. So what is the risk for parents with PTSD? So we know when you look at the research that talks about what makes the risk for parents around PTSD, the interesting thing, and I want to step back and highlight, one of the sad myths that are out there, or wrong conceptions about PTSD, and even this recently happened when someone said, oh, hey, what are you doing this weekend, team? And I shared what I was talking about. And the first response was, oh, is that not something only veterans of war get? And I thought, no, it's not. So we have lots of work to do. I think everybody who's suffering with PTSD, we have a lot of work to help understand that it's not just a mental health concern for those who are veterans of war, that anybody who's experienced trauma, and this is why the DSM has very specifically identified the criteria. So I wanted to really focus on what makes an increased risk for PTSD for parents who have a child with cancer. One of them, of course, is, as most parents experience, is that financial strain. I began my presentation with recognizing that in a matter of a night, and for some it's very quick, your life is completely changed and you have to reorganize everything. So that financial strain is a risk for parents because it's not, you've lost everything that you've worked for and you had to reorganize, and which a parent will gladly do for their child, but it doesn't mean that there's not an implication on you as a parent. Limited social support, including coping tools. So as a parent is walking through this journey, they're busy, they're going to hospital appointments, they're attending all of these accountability things for their child, and yes, you want to, but the thing that happens when all parents do is they start giving up their own things. They start giving up, I'm not going to go out with my friends tonight, I'm just too tired. I don't feel like going for a run, I'm so exhausted, I'm just going to stay in tonight. Gym, I don't really need it. Can't afford it, don't need it. I'd rather just put my feet up. I've had a long day at the hospital. So as a parent is drawn in further and further into their childhood cancer journey, the more you start letting go of those things, what we call self-care. So it becomes really, really important when we start thinking that, is this being selfish? Like, I should probably stay at home because, you know, my husband's there with the other kids and I just got back from the hospital. It's probably not fair if I go and do something for myself now. I'm just being selfish, and you feel guilty, so you choose to, I better not do that. Very common responses, but as we know, not a great way to manage in self-care. So I'll talk a little bit about that as well in a second. The sudden shock. So again, change very quickly. It's that sudden abrupt shock. As all trauma is, trauma comes out of nowhere. But again, this is in addition to everything else a parent is going through. Prolonged exposure to social, emotional, financial, and medical stress. So when a childhood cancer journey starts, it's not a short journey. For some, it is years and years. So that prolonged exposure makes parents that much more at risk because of that prolonged exposure to the trauma. The other part is that for PTSD, and what causes the risk for parents, is that there is the continued concern of post-treatment outcomes. So there is this fear of, yeah, we're done treatment now, but I don't get to shut off my fear about what the future looks like. What does that look like for me? So you're constantly, potentially triggered by another parent's story, thinking, is that going to be my child's story? So the thing about this for most parents is the fear that occurs for future is so overwhelming for parents that this creates another risk factor for PTSD for parents. This is the other part I wanted to highlight, and this is what's really hard for parents. When I talk about, even with my own clients, and I express this concern, if you have a history of trauma, so if you have developmental history, so developmental history is where as a child with your own family, with your own parents, there's been trauma. Or even as a teenager, there's trauma. And trauma remembers anything. It could be car accident. It could be repeated exposure to violence. It can be a parent who has a mental health disorder that may not have been able to parent. These are considered traumas in the life of a child. So if you have early trauma that's not resolved, this actually can be a compounding feature as to your own journey as a parent with childhood cancer. We can't talk about PTSD and not be aware that our own unresolved issues, paired with the compounding effect of childhood cancer, can cause an increasing significant risk for PTSD. So it's just something for everybody to be aware of. So what can happen? So here we are, we're recognizing that perhaps I've had post-traumatic stress, or perhaps I'm in the process, I'm recognizing all these signs and symptoms, and perhaps a parent out there has PTSD. What does it look like, and why should we be worried about it? The part that occurs is parents do put their own needs aside to care for their child and for their other children, to be present, and putting their needs to the side has a ripple effect. And what does this ripple effect look like? It is very common for parents who are overwhelmed with these post-traumatic stress and perhaps PTSD that it's moved into that complying with the medical terms or protocol becomes overwhelmed. They become overwhelmed. You forget dosage. You forget, did I give my child a dose today? They don't follow the schedule. So when you go to see the oncologist and say, did you give a dose? Oh, I forgot. And that becomes the parent who forgets the dosage, forget about details of the protocol, because your short-term memory is now not necessarily where it should be. So it becomes a problem, especially when it has a ripple effect onto the children who are diagnosed, and to your other children, because you're not parenting effectively. You could be missing appointments and calling them and saying, oh, I just forgot an appointment. So there is an implication as to what occurs for that parent and whether they can actually parent and be a part of that childhood cancer journey in an effective, healthy way. It is often not until, as I highlighted earlier, that most parents, when the treatment is done, that they now become aware of what they've experienced. It is not until then that parents get therapy or they get help. But what I'm really suggesting is that when everybody, as a parent, is recognizing that they're having these symptoms, it is actually more conducive to get the help when you're in the journey. Because what I always tell all of my clients who are parents who bring their children to see me, I say, I work as a family systems. I work with the parents to help the kids. We've got to work with the whole picture, because when the parents are healthy, we can only be there much better and more effectively for your child. So it becomes so significant to recognize that it's not a bad thing to go and say, I'm going to go to the gym right now. You're not being selfish. You're actually doing the opposite. You're taking care of your health so that you can be more effective and more healthy for your kids. So it's recognizing that when you hear the validation of it's so important, and parents, when you're talking, being able to validate and say, no, you need to go and do that. It's keeping the parents accountable. No, don't give up that social opportunity. You should go. It's so good for you. And validate that this is what needs to occur. And it's always going to happen first in the informal settings, because before parents come to see a professional, they've lost all of that opportunity to hear that informal validation. And as parents, we need to do that for each other. I talked a lot about earlier. So again, you're letting it go. So now we're at the maladaptive coping. We've let go of all the self-care. Our body, our brain needs some ways to cope. We can't stay in this hyper-arousal state. We need breaks from it. So what occurs is if you've let go of all the great sustainable coping, you will gravitate to something that's maladaptive. The quick fixes, the moment I'm doing it feels great. I might shop. And as much as those that like to have therapeutic shopping, it's not necessarily good for you. It feels great in the moment. But shopping, any of those things that you remember, you only feel good in the moment. Exercise, there's a lingering effect, right? It's good for your body, it's good for your brain. But maladaptive coping, like drinking and drugs, it's not a good choice to make in this moment. So that's when you have to recognize what choices am I making to take care of myself. And there's things you can do. Right now, you may not be able to see a professional, but self-care is a means to doing that. And one of the analogies I give parents often is thinking of a scale. When you're in a childhood cancer journey, you have a lot of things that you can't control. So here's a scale, and if you can think and envision, on one side is all the things that are piled on the one side that you have no ability to control. So doctor's appointments, checkups, treatment, and if you're in the midst of active treatment, you can't control any of those details. On the other side is what you get to control. So here we are. If the scale is on the heavy side of those that you can't control, you only can manage it by bouncing off. It's not a cure. It's management. So you always want to at least try to keep that scale in a balanced way so that you're managing the things you can't control. So management looks like self-care. It's important to acquire everything that can allow you to feel better in that moment. It helps to manage the things you can't control. So I have done a handout for those that are here, and I'm not sure if it's posted for others to see. It's a little bit more of a thorough document. I just wanted to at least provide everybody with activities or ideas of what it looks like and how to take care of yourself. I know that when you're in this journey, there isn't always a lot of time, but there is always something that people can do. And the reason, again, we want to do this, it is a preventative to feeling post-traumatic stress and to preventing post-traumatic stress disorder. These 5 areas of therapeutic care, and you're open to anything. So I've identified them on the slide as physical self-care, lifestyle self-care, mental emotional self-care, social supports, and spiritual connection. There is going to be something different for everybody, but within each of those themes, there is always something that someone can do. And it should be consistent, and it should be something you look forward to. It's something that gives you a sense of peace. You may not feel overly happy when you're doing these things, but at least you have some means to take care of yourself, and that is the ultimate goal. So when should you seek professional help? So I've talked about a few things that really make it important. I suggest to everybody that just as a preventative, as soon as you feel these stress symptoms come on and you're not managing, just talking to someone. Support groups are great. They help to normalize and validate, but you also have to be checking in with yourself. If every time you go to a support group and you leave feeling more overwhelmed, that's probably a good place to recognize, is this actually healthy for me? Am I actually feeling worse going to this group? And that's where, again, we have to consider that vicarious trauma is overwhelming for some people. So you may need to actually seek out a professional to get that assistance. For some people, support groups are fabulous. They're getting validated. They're feeling like, okay, this is good. I'm hearing this from other parents. So when you need to seek is, again, persistent symptoms that do not go away. You're not functioning in your normal, as possible, normal life. If you're working, you're still able to attend work. You're still able to get to appointment. You're still able to manage your child's treatment protocol, all of those things that you have to do, you're continuing to do. If not, it's important to get assessed. I always suggest a psychiatrist, family doctors, so there's some great family doctors out there. Psychiatrists are specialized in mental health, and the psychiatrist or family doctor can provide a diagnosis if necessary for PTSD, and then you can find a therapist that will help. I'm only going to touch, I'm not going to go into detail about the therapies, but I really wanted to touch upon, because I have lots of people say, well, how do I know which therapy is great? If you're struggling with trauma, so I'm talking about trauma, and then if it moves to PTSD, there's two therapies that the World Health Organization has recommended pertaining to trauma and post-traumatic stress disorder, and one of the two. The first one is eye movement desensitization and reprocessing, or EMDR is the acronym. It's a little bit more complex, but I can certainly answer any questions if anybody has questions pertaining to therapy. It's a fabulous therapy, probably a little bit biased because that's what I do for a living. I do a lot of trauma and I'm trained in EMDR. I've seen fabulous results, so it is an amazing therapy. And cognitive behavioral therapy is another recognized, well-researched therapy, so or CBT is another, the acronym for that. So again, if anybody has questions about those therapies, I can certainly answer. But those are the two treatments in terms of that they've recognized in research, that they've had stats on them and they're well recommended. Okay, so I wanted to, and I had shared with the board earlier, I was going to touch upon this a little bit about what the future is needed. I recognize that the research, and I think all of us who work in the mental health recognize that the research is needed, in particular about parents and their siblings around post-traumatic stress on this journey. There's not enough research. There is research coming out, and it's all sharing the same thoughts, how overwhelming this is to parents and how we need to find and support families because these particular diagnoses does cause such an implication to the parents and how they parent. So we're recognizing that. One of the tools that I had been talking to the board about, and I'll just touch briefly about, is there is an assessment tool. So it's something that identifies where the needs are in families so that we can fit a particular program or resource or tool to that family and be able to treat each family as individual families. And it's important because every family we want to draw upon every family's strength, because families do bring strengths and families do bring weaknesses. So this is a great opportunity to be able to touch upon that. Developing more approaches in the hospital, in their communities to help families, specifically around childhood cancer. That is certainly, I think all of us dream of that. So that is something that, again, when we support the families more, the better they will feel. They have some sense of power over the process. Normalizing, and this is something I put out to everybody. Everybody asks me, what can I do to help that family? And I say, simply go to them, sit with them, hug them, listen to them, and normalize it. Validate them. I hear what you're saying. That must feel really scary for you. You don't need to fix it. And I think that's most significant. So when you're looking to provide advice to people, it's that realization that all I have to tell them is just be here with me. Be present in my life. Don't leave. And that is such a powerful, powerful experience for parents. And again, we need more additional resources for PTSD. So I just, again, wanted to show a quick model of what is currently happening so people do know that this is certainly being researched, that certainly we are very well aware that support is needed for the parents, and there is things that are happening. So this is a tiered response as a result of this psychosocial assessment that's done, and they're identifying that families do fit into different tiers. There's families at the universal level that come with many supports, come with many resiliencies and strengths, and that they may have some gaps, but we fill those gaps still. And then as you continue up the tiered, there's those who are targeted and those who are at a clinical or treatment need. And then the hospitals are filling these gaps. So if at the clinical and treatment need, the parents are needing to see a therapist, they have access to that. So it's a great model to see and something that's happening in the States, and certainly I know that OPACC is looking into it. So it's just something I wanted to share that the parents who are listening, there is research, and if anybody's interested in seeing what's happening, by all means you can ask, and I'll be able to give answers however I can. Okay, so I wanted to really end the presentation with a couple of quotes because one, it really does normalize everybody's experience with childhood cancer. It's a hard quote to read, but I wanted to read it because it does help to normalize a really good way to view what it feels like as, of course, as a parent. So as a parent, we want the best of and for our children. If they are hurt, we hurt even more. If they have achieved something they are proud of, we are even more proud. Childhood cancer takes our ability to parent, knocks it to the ground, and stomps on it. It's not like a cut that we can bandage, nor like a cold or broken bone where you can take your child to a doctor to fix. Cancer renders us helpless. So it becomes so important to recognize how helpless a parent does feel, and I absolutely recognize that as a parent myself, going through this journey. And validating that for parents is so powerful. But to end with that, and this is where we have our choices, that's why I didn't want to just leave with this quote, because we do have a choice, and I thought this really sums it up. When something bad happens, you have three choices. You can either let it define you, let it destroy you, or you can let it strengthen you. And we have that choice. So I always encourage families, think about what you want to do with this journey, because that's what's going to empower you, and that's what's going to begin to encourage and help families and parents move beyond the symptoms that they're experiencing. So I'm happy to take any questions at all.
I have a comment on that last quote.
Yeah.
It can actually, I think, do two. You can let it define you, but you can also let it strengthen you.
Yes, absolutely, absolutely.
I look at that and that's myself. I've taken the two, and anybody who would work with me years ago and stuff like that would say, yeah, it kind of defines them, but personally, I think it's strengthened me. So.
Yeah, I would agree.
I think one of the questions I have, and perhaps some other people around the table can actually help answer this question though, but within a healthcare facility environment, so within a hospital, let's say, like Sick Kids or RVH and Barrie, is there a recognition amongst the healthcare team and social workers or psychologists around PTSD and the impacts that families may be having as they struggle their way through their own cancer-related journeys?
So,
No, go ahead.
So I will, from an adult perspective, I think there is a recognition through our social work team that people experience depression. I don't know if they actually tie that back into the bigger picture of PTSD.
Mm-hmm.
And even in, thinking about people who I have talked to who have gone through that journey, I mean, there's elements of things like, so I've been very open. I've had somebody in my family who's had PTSD from a traumatic event. And even when I look at the treatment options, I mean, what were classified as PTSD, but then the treatment was a treatment for depression. So I think there's still they're not sort of putting all the pieces together. I think we're recognizing the symptoms of the sleeplessness and the depression, but not necessarily putting it under that larger umbrella. And I think it goes to the comment that you said earlier that people still think
on your phone
PTSD is related to the military, and they don't relate it to all these different events that are very traumatic.
And the hard thing too is that even in the adult system and the children's system of mental health is that they're getting other diagnoses. So a child who comes off a treatment may get depression as a diagnosis rather than saying that, is this not PTSD, and if we treat that, is not all of these other mental health disorders going away? And often that's the concern, is that when I have clients come to see me, I will do a thorough history, and I will often find trauma. And so through the EMDR process, we resolve that trauma, and all of a sudden the symptoms start to dissipate. And they're like, okay, that's a little bit bizarre. I'm not feeling this way anymore. And I say, well, because we treated what's caused the result of the diagnosis. Yes, there's some individuals out there, so children and adults who do have significant mental health disorders. But if we do enough work around understanding someone's trauma history, we can often define what has resulted from. And then in the hospital situation, I'm going to just talk about the children's part of the hospital situation. the people that are hired in the pediatric oncology is that often if you're seeking out information or seeking out support, so you have your psychology staff and you have your social workers, and social workers are more case management, so they'll want to disperse the families and connect with supports, and sometimes they'll be there in presence. But the therapy part is the psychologists come in and try to do the treatment. However, they're designated for the children. So as much as you're reaching out to the psychologist to get the support, what they're trying to do is give you some parenting strategies, but you may be saying, I kind of need the help though. I'm the parent that's struggling, but they're not mandated in the hospital to help. So there isn't any particular clinical staff member in the pediatric oncology that is strictly for the parent, and that's what makes it hard.
And I think that's the model of sick kids, is that case management in the adult facility where I'm at, and there's not a cookie cutter approach to your psychosocial oncology program. My social workers don't do case management, they do that support. However, in an adult cancer structure, and it's very much focused on that treatment phase, and this often occurs post-treatment. And so I think that's the disconnect as well. And, you know, we don't have any psychologists or psychiatrists connected to our program. And I would say that it's not something the oncologist is necessarily well-versed or comfortable in. And so, you know, your comment about going to see a family doctor or a psychiatrist, and my other program is psychiatry, there's a huge wait list to get to psychiatrists. Some family doctors are adept in dealing with these issues and know about the tools, but I still think there is that challenge.
And there's the validation that even the families who say, I do need to access a psychiatrist, and there's not a lot of trained pediatric psychiatrists. So where I practice, I may have access to two, and their wait lists, of course, are very significant. And it is better to have a pediatric psychiatrist, especially in this journey, because they just understand and they interact with children differently, but we don't even have access to that. And that's just a validation if anybody's frustrated with the system. That is across the board a problem. And so, yes, family doctor becomes the next go-to place you can go. It's OHIP covered. They don't necessarily give an appropriate diagnosis. They want to help treat the symptoms, and then you're left with, what do I do? And then for the parent, yes, there's options, but it's not necessarily as available as it should be. So.
I have a couple of questions and comments from online folks. So from Anne, there's a comment, thank you for the session, very helpful to see we are not alone. So that's great. Thank you, Anne, for listening in. And there was a question from Neil. He thinks you may have answered it, though. He said, are there any mandated psychosocial standards of care related to childhood and AYA cancer currently in place in Canada? But you were just talking about that a little bit, so anything else?
I think just to add to that part, I know that, I mean, we've talked about how disconnected, especially in pediatrics, oncology, and I would say not just oncology, in terms of working with both mental health and physical health. So there certainly isn't as much. I've seen a lot more effective practices and best practices in the States, and that's where we're hoping to start looking at what is really occurring so that more of us are working together and not working in silos. So I haven't heard of any particular model of care yet, as in Canada, around the mental health piece for parents in particular. They're certainly establishing different groups for children, and a lot of, again, these groups are based on symptom management, and they're great, and it's there, but we need to look at all rounds of the person. And a person isn't just about symptom management, we need to get to the root system. I even explain to adults and children that when we think about a person, we have to think about them as a tree. And it seems like a bizarre analogy to think of, but if we don't treat the root system, we're not going to have great branches. So a part of our programming is very much symptom management. We need to manage the symptoms because we don't want people's mental health to become unmanageable, but we also need to deal with the root system, and this is what I would say, is that we're not very good with dealing with the root system in the hospital, and sometimes not in the community unless you're willing to pay for it, and that's what's hard. So across the system, that's typically what it's like. Yeah.
Oh, thanks very much.
Oh, you're very welcome.
I guess my question is around, there's probably a community of moms out there that are ready to do something about their PTSD, and maybe the treatment, they're past treatment by a couple of years.
Yeah.
And I think some of the struggles that we have is, where do we actually go? And how do we address the root system? Because you don't have time, we're all parents, so how do you shop around for the right counselor? Like, what sort of treatment should we be looking for? Those are the pieces that I was coming for. Like, I wouldn't mind knowing, like, who would be some good people to approach. in terms of addressing PTSD? I think we're dying to know.
I know. So what I would recommend first, look for the community agencies. So the larger the center. So Toronto, you would have more not-for-profit agencies that will have trained, whether you want an EMDR therapist or CBT, you will have people who are trained who provide for those. So I would first look there. What I say to all of my clients when they come to see me is that if you don't feel connected to your therapist, the number one, and we know research has shown this, if you do not connect with your therapist, that will actually cause more of a disservice to you. So shop around is a great term. It sounds bizarre to say that in the mental health field, but you have to. Don't give up on therapy. So word of mouth is good. If you have anybody who's been to a therapist and said, yeah, she or he was really great, I would start there. You will find in the not-for-profit sector it is very different. So I'm just going to let everybody know this because some people feel very frustrated. They will tend to have a session cap. So depending on their funding, there can be some great organizations out there that allow for more sessions. But often because of their funding, they do have session caps. So first thing would be, you could certainly try that out. Look for the organizations, calling around to see if they're trained in EMDR or CBT would be your first thing. If it's not for profit, set up an appointment, at least go to 2 or 3 appointments before you know if it's a good fit. So some people go the first session. First sessions are hard to determine whether it's a good fit. I always suggest at least go to 2. If it's not a good place to go, you will want to also ask how many sessions are provided to me if you're going to the not-for-profit sector. You want to find that out because if you have significant trauma, you'll want to go with some goals. You'll say, yeah, I just went through this journey. But if you have trauma in your history, working on this piece may not alleviate all your symptoms. So you have to be aware of going into the process that you may have other things that you have to work on in addition to this. For those that can afford, there is always the option of insurance or EIPs, but EIPs also, so employment assistance programs, do have sometimes session caps as well. There's limitations on those. And insurance, depending on the insurance company, depending on what your portfolio is in that insurance company. So finding out those. So I'm going to just summarize because I just said a whole bunch of different things. So I would first check out what's in your center. So check for the not-for-profit that are strictly deal with therapy provides either EMDR or CBT. Ask about how many sessions they provide. Try the therapist for at least 2 sessions. If you're looking for the private sector, ask around within your group of friends who may be out there. And then, again, 2 or 3 sessions. See if you have insurance or EAP that will cover for that therapist. The other part that I hadn't already added is you can go on. So if you're looking specifically for EMDR, EMDR has a very strict regulated body. So you can go on the EMDRIA, so it's EMDR, so it's the international website for EMDR. You can actually go in and see who's in your area that's trained. So you can just put in your area, your location, and it will come up with therapists that are trained. So that's the other option.
Would they list organizations under that website that might have
therapists trained? I'm trying to think. Usually they go by name and what their credentials are, and they may suggest, they may list who they work for if it's an external.
Because the only other idea that pops up in my mind, speaking for the not-for-profit sector, is in Toronto there's 211. So if you were to call 211 and ask them specifically for organizations, they may be able to pull up the database and then go through them. The only one that pops into my head is CAMH as an adult one.
Community Mental Health Association. And I would be picky, right? Because I don't mean to say that we're all special, but we have a very unique experience. And just even the fact of trying to talk about the many valleys of our journey. I guess you want that. You want someone who gets it. Who gets what it's like to parent a kid with trauma.
And to validate that, I mean, I've had some clients come and say, I went to this therapist and she or he was trained in trauma and had this, but they just didn't get it. And that's a hard thing. So sometimes recognizing that as you go into the community to look for this person, you may be limited on a therapist who is also has a child that's gone through the cancer journey, because that pool of people becomes very less. So what you want is, what your evaluation should be is, do I feel connected to this therapist? She or he may not get completely, but at least am I feeling validated and normalized, and are they not pretending to know what I'm feeling? So that's what's hard. So I would rather tell my parents, what I tell them is I'd rather get the help that you need and make sure that you can at least go in building a relationship, because absolutely, do you want someone that has a similar experience? Yes, that would be great, but it's just not always going to be out there.
I'm just going to get to the questions online
Yeah,
first before
Sure.
the other one. So a question from Neil. As much as the parent of a child or cancer patient never wants to hear the word palliative due to its hospice-related associations, do you feel that palliative care should be brought in and offered to parents much closer to diagnosis?
Yeah, it's a great question. And so that is hard. So when you have a parent, when you have a child who is going to be in palliative care, and it's kind of two tiers. When we think about the child, do we want to have those conversations with the child? Absolutely. We want to be able to get them to express themselves and share their story and to, journal, and we want them to help it through. We don't just want to abruptly say, this is what's happening. That child is going through a journey themselves. So do we talk about it early? Absolutely. Do we bring in palliative care as a process? Mm-hmm. Absolutely. We can't just abruptly change a child's life and a parent's life without making it a process. It is hard for a parent to all of a sudden abruptly do things to reprocess and integrate all of the things that they're going through. So if all of a sudden it's happening and it doesn't happen until the end, it's not fair to both the parents and the child. It's something that needs to be processed, mm-hmm. and it can take a long time. So the sooner the better, often, because then you're working with the parents. And again, we're looking at not just we're looking at preventative strategies for the parents and the siblings. That if all of a sudden this just happens just last minute, how is it helping the parents and how is it helping the siblings? It's a journey that needs to be processed together as a family unit. So it's all about being able to have closure in a healthy way. And that's what's hard when it comes down to palliative care. It's probably one of the things when I have families who come in and say it's not fair, I say absolutely not fair. And that's such a difficult journey. And how can we make the journey easier? It's not easy, but how can we make it easier so that you can process and create a story and honor that story? So it is, it's a hard, I hope I answered that question.
Thank you.
Is there any other questions there?
No. Go ahead.
I just wanted to go back to your comments more earlier with regards to the resources, and that I know you're planning on putting this up online on OPACC site. And I think if you haven't thought of it already, it would be really helpful to list, those steps that you included, and maybe with some examples of the community resources that you recommend. You can't list all of them,
absolutely,
no,
but just to give people some ideas as to where they go and to take it to the next step.
Mm-hmm.
That's a great idea.
And sorry,
Barbara.
Yeah, and I was just going to go back reflecting on some of the stuff you said, because where it goes from PSD to PSTB, and it's like one of the things is that oftentimes the families, and you talk about the first month, but depending on their journey, one of the terms that I came on, especially if you go through relapse or then if someone goes into palliative, that you as a person are in a crisis mode for a very long time.
Absolutely.
And depleting your cortisol level, which helps you with stress, that can, as you made the comment of sometimes after treatment, people say, well, you should be able to get on with things and then you should be fine. But you stay in that mode, fight or flight, anxiety during that time, and then when you're done, you fall apart. And I think it is the realization on what can we, as you said, maybe you are going to be in that crisis all along, but what little things can you do while you're in that crisis to help so that you won't crash as severely, maybe. But I did want to sort of validate that, because our journey can vary, and it can be, like you say, yes, the initial month where you see some of this, but all of a sudden things are better, and this next part happens and goes onward.
Absolutely.
And I did have a question, because I'm very familiar with the, you were talking about the two different types of techniques of cognitive behavior therapy, which I've actually done a workshop on that. But I'm not at all. Can you just really quickly?
I can.
What eye movement desensitization?
Okay.
Yeah.
So, without getting too complicated about what EMDR is, what we do with EMDR is we understand that when your brain goes through trauma, we need to isolate that trauma and target it and reprocess. So our brain at night on its own during REM sleep, and this is what neuroscientists believe occurs in our brain, is during REM sleep, so rapid eye movement, this is where our dreams occur. During our dream state, during REM sleep, our brain naturally reprocesses. So if you think, why did I wake up and have that bizarre dream? It's because your brain is actually integrating things of that day. it naturally does that. And so here we are in traumatic state. Our brain actually cannot continue to do that. And I'll have clients who even come to me and say, Tina, I have the same dream over and over. And I'll say, okay, you know what your brain's doing. It's trying to fix it. It can't. It's in this looping. So I have clients who actually come and share the exact same dream because the brain is stuck. It can't. It's in this looping. So what we do is we target. So we look at trauma history. We look at negative events. So not everything's traumatic. But in this case, we target the trauma and through what's called bilateral stimulation. So we actually mimic what REM sleep is. So if you look at someone who's in REM sleep, their eyes are going back and forth. We mimic that, and that actually begins the process of integration of these targets. And so what the brain does is goes from left to right hemisphere. The left hemisphere is where all of the negatively stored information is held. The right hemisphere is where all of the adaptive integrated resources. So these are resources that we've all had in our life. So it could be happy memories. It could be our friendships. It could be all the stuff that's empowered us. It's already waiting and stored in your brain. The hard thing is, I never give this analogy for people to think about. If you had an imaginary bridge in your brain, what's occurring when it's healthy and processing, your brain is able to get to the other side, back and forth, and naturally do that. But all of a sudden you have trauma. There's a hole in that bridge, and your brain is stuck. It can't get to that adaptive part. So EMDR comes in, and we start filling in that hole. We start doing bilateral stimulation. It's a whole protocol. And we start helping the brain process at a very accelerated rate. So we're actually accelerated beyond what REM sleep is. And the brain starts to naturally integrate it. It's fabulous to watch because people in their own ability start integrating these negative memories. And they start saying, and I have it so funny, because people will say to me, Tina, I have no idea what you just did, but I can't believe that I feel this amazing when I came in feeling this crappy. So the power, and so this is what's happening is people who are veterans of the war. So it started with people who are veterans. This is where it started. And they're now starting to change PTSD in veterans of war. So we think of what veterans have gone through, and it's now significantly changing, and their PTSD is now being diminished. So this is where it's being branched out, and lots of people are getting trained. It's very, very significant training. Lots of hours are needed, and there's a regulatory body, but it's fabulous. It works what the brain does. And what the other part is, what EMDR does, and no other therapies can, is we can actually resolve infancy trauma. So if you have a baby who's born at birth and was in significant trauma, whatever it was, car accident, tornado, maybe violence in home, we can go through their somatic memory. So our brain holds everything somatically, so a baby or an adult won't have those memories, but in our body it holds, so the brain remembers everything. So we can actually go and clear that trauma from birth by doing EMDR. Yeah.
In the long term?
Long term, you never have, so once that target's cleared, it's cleared.
That's it?
That's it. Because your brain is integrated and adapted it.
And so on average then, how many sessions?
So, great question. What I tell everybody is that we do it in comparison. So what research has found with EMDR versus traditional talk therapy, so traditional talk therapy is like CBT, it is faster than traditional talk therapy. So say I said to someone you're coming for 10 sessions, that 10 sessions in EMDR would be reduced. So it's a lot faster, and for people who have trauma, to even have to talk about that trauma continues to re-traumatize them. So EMDR, we don't even need a full explanation. So initially, we always do thorough history, but you don't have to keep talking about that. So with EMDR, yes, we're stopping to make sure the brain is processing. You don't have to give full-length stories where in talk therapy you have to, because people are feeling overwhelmed. I don't want to keep talking about this with EMDR, you don't have to. You trust that the brain continues.
I have a comment from Neil.
Mm-hmm.
He says, thank you for your choice to repetitively use the word integrate. There is no fixing what cannot be fixed or reassemble a puzzle that is missing a piece. Learning to integrate loss so that a bereaved parent may continue forward to seek personal redefinition and purposeful meaning in life. Congratulations on a very informative, useful presentation.
Thank you very much.
It's interesting that you talked about history and what have you. You know, and I look back at my own life. My dad died when I was 14. I had a sibling die when I was 25. What have you? I sort of jokingly say to some people in that, grief and I are pretty good buddies.
Yeah. Yeah. And that is trauma, right? Losing a parent at a young age is so significant for children.
Yeah.
So, it's hard.
And then this.
Yeah, and this makes it hard.
Very well done, Tina.
Very well done.
Thank you so much,
Thank
Tina.
you.
so much.
You're
Thank
very,
you.
very welcome.
Good
It's my
job.
honor to be able to help.
So Ryan, we are going to post this on the OPACC website.
Yeah, we'll post a link. I've recorded this session, so it'll be posted and shared with others, on social media and and online. And if anybody online has any questions that you could think of after the session is done now, just email us. I put the email on there, info@opac.org.
I was just going to ask whether or not if we could see if Neil would be comfortable with us sharing that last quote in
Yeah.
relation to this talk, because it's very powerful.
Yeah, it's great.
So, yeah, if you can.
Neil, if you can hear me still, we really like the last quote that you gave there, and we were just asking permission to share it. And Neil says, thank you. Okay. And he says, granted. Thank you, Neil.
Great.
Thanks, Neil.
And the only last comment that I want to make too is on behalf of OPACC, we have been talking with the palliative care team here at the Hospital for Sick Children, because one of the big questions that has popped up time and time again is how soon do you start that discussion? Because their feeling is that palliative care should actually start at the point of diagnosis, not necessarily because palliative care means bereavement or bereavement support. Their view on palliative care is that broader continuum of support and linking parents and families to additional supports like OPACC and our parent liaison program, as well as to flag if there's any issues for discussion. So we've definitely been asking our membership through OPACC to continually give us suggestions and feedbacks as we continue that discussion with the PAC team. So I just wanted to flag that's what. Okay.
And it's also very culturally dependent, right?
Yes.
Some cultures are open to the idea, and
Some
others
aren't.
not.
You're so right.
And if they wanted to do that, they can't call themselves the palliative team.
That's right. Yes.
I would not.
I think
No,
that-
We're all not.
Yes.
Pediatric advanced
Care team. That's what
Yeah,
that's
yeah.
what they
name
changed
change.
their name.
It
The
is
name
called
has changed,
change.
actually.
Yeah, I hear that, I know it's
Oh,
probably
trust
bad.
Yeah,
Yes.
I
I know.
Full language is hard to
Yeah.
kind of.
Yeah. Yeah.
They're
No.
trying to change the name, they're working on
It,
And that
it's
would
just
be-
interesting that these
Yeah.
discussions are happening,
It is, and I think that's respecting the family's boundaries, right? So if you don't necessarily know that that's the child's journey, you need to ask the parents that, is this something you would want to invite into your process? Because then you're respecting that parent's boundary, because for parents who don't even want to go down that path, and they don't even know it is a part of their journey, we have to respect that might be,
Yeah.
exist for
That might cause
But
more.
We're looking at PTSD.
Vicarious, yeah.
Absolutely. Do we want to cause further fear in a parent's life when they're already faced with what they have to deal with? So.
Yeah. Very good points.
Okay, thank you, everybody, for joining us today. Thank you.
Thank you.
We're going to end it now.
Thank you all.
Bye-bye.
Thank you.